Hello everyone, today let's discuss about chronic periodontitis. By the name itself, we know it's a infectious disease or an inflammation would be there. So the definition says that it's an infectious disease resulting in inflammation within the supporting tissues of the teeth, progressive attachment loss and bone loss. So here it's a complete destruction of the periodontium that is happening. That is why they in the definition they told that it's a attachment loss, bond loss, everything. So it's a complete destruction of the supporting tissues due to the inflammation. Let's see how we can clinically identify this is a chronic periodontitis case. Clinically, definitely the calculus would be there. They are the major etiological factor of the spread of this chronic periodontitis. So that calculus would be there. Then all the destruction in the gingiva can happen. That means gingival swelling, redness, loss of stippling, altered alveolar, altered gingival margins, everything would be there. So the destruction has happened in the gingiva. Then next come to the destruction of the periodontium. That means attachment, periodontal pocket formation, BOP, bleeding on probing, attachment loss, bone loss, furcation involvement, tooth mobility, change in the tooth position, tooth loss. These all can be seen in the case of chronic periodontitis. See, when you see this picture, you will understand better that this is the healthy tooth. This is the periodontitis case. Here you can see here the gum is normal pinkish in color. Here it is reddish and rolled gingival margins. Everything can be seen and reddish gums. And when you see here, you can see the plaque and tartar, bone loss, periodontal pocket, all can be seen in the chronic periodontitis case. And how we will diagnose clinically by PSR, and also we can measure the loss of clinical attachment, and by the radiograph we'll come to know about the extent of the bone loss, how much bone has destructed. So these all are the diagnostic criteria for the chronic periodontitis. Then we will discuss what is the differential diagnosis. Sometimes the aggressive periodontitis can be confused with the chronic periodontitis clinically when the patient comes to the clinic for the first time. So when we first examine, sometimes it may confuse with the aggressive periodontitis. So we can differentiate that by the rate of disease progression over time. See, in the case of chronic periodontitis, when we do scaling and root planing or such initial treatment, some kind of improvement would be there. But in the case of aggressive periodontitis, the progression would be very high over time. And then the aggressive periodontitis is little bit of that is familial in nature, and we can identify these two by the presence of local factors and the presence of systemic factors. Then sometimes the plaque-induced gingivitis and chronic periodontitis can be confused. Plaque-induced gingivitis means the inflammation can happen only at the gingival level, not into the periodontium. Whereas in the case of chronic periodontitis, attachment loss, as I told you just now, that attachment loss, bond loss, everything can be seen. This gingivitis is reversible if we give a proper oral hygiene measures, everything, it can resolve completely. But in the case of here a chronic periodontitis, once the attachment loss has happened, it is irreversible. Even if we give a successful treatment, it's irreversible. And not all sites with gingivitis progress to periodontitis in the case of plaque-induced gingivitis, whereas here all patients with chronic periodontitis must have experienced some prior gingivitis. Then the dental implant counterpart of gingivitis is peri-implant mucositis. Here it is peri-implantitis. Then we will discuss about the classification. Based on disease distribution, it is divided into localized and generalized. Localized means only less than 30% of the teeth show the attachment loss, bone loss, everything. The remaining tooth would be super fine. Here generalized means above 30% of the teeth show the attachment loss and bone loss. And based on the disease severity, it is divided into mild, moderate, and severe. Mild means attachment loss may be only 1 to 2 millimeter. Moderate means 3 to 4 mm. Severe means above 5 mm of attachment loss would be there. Then we will discuss about the risk factors. First is the microbiologic aspect. We know that the plaque accumulation is the primary initiating agent in the etiology of gingivitis and periodontitis. So we need to understand which all are the organisms that is present in this case. As I mentioned earlier, lot of attachment loss, bond loss would be there. Because of that, in such cases we can see gram negative organisms. They are the red complex bacteria. If the calculus is supragingival, there you can see the gram positive organisms where they need oxygen to survive, whereas here the gram negative organisms, they doesn't need the help of oxygen to survive. So this kind of cases, the gram negative organisms are present. They are the Porphyromonas gingivalis, then Canarella forsythia, then the spirochetes. They are the Treponema denticola. These all organisms can be seen in these cases. Then the local factors such as the calculus, crown margins, overhanging restoration, furcation, then a deep probing depth, anatomic grooves on the roots, subgingival caries or resorptive lesions, these all are the local factors. Then systemic factors. Definitely we know that the diabetes, these all can affect the chronic periodontitis case. Then HIV or AIDS, like the immunocompromised cases, this can be seen. Then osteoporosis, like that. And this is a table of the abbreviated version of the 1999 classification of periodontal tissues and conditions. In that they mentioned that periodontitis as a manifestation of systemic disease one is associated with hematologic disorder like leukemia, acquired neutropenia and all. Then associated with genetic disorder like certain diseases and syndromes, and other unspecified reasons. Then genetic factors, then environmental and behavior factors like smoking and tobacco, stress and depression are there. Then next is the treatments. Treatment is the systemic periodontal therapy. They are the optimal long-term plaque control, then the debridement of soft and hard deposits, then a surgical pocket reduction by the surgeries like resective osteosurgery or the regenerative surgery. And depending on the individual periodontal risk, each patient should be remotivated and re-instructed and retreated if necessary, and during a systemic supportive periodontal therapy regimen, and they have to revisit every 3, 6 or 12 months. So this is about chronic periodontitis. Here there are a lot of questions are there. I will answer these questions one by one. First is periodontitis as a manifestation of systemic disease as described in the Armitage 1999 classification include leukemia, I told just now, hematologic disorder, then certain genetic factors, these all are included in that. So leukemia is the answer. And here this I will discuss late in the next class about repair. That is my next class. Then the other question is the periodontal, the predominant microorganisms associated with periodontitis are just discussed now. It's gram negative anaerobes like spirochetes, P. gingivalis, Prevotella intermedia. These all are the gram negative organisms. Then initial scaling and oral hygiene instruction in the treatment of periodontitis results in all of the following except. So after initial scaling and oral hygiene instruction can happen all these like pocket shrinkage, that is the main purpose of SRP. Then while surgery, the less hemorrhage, so decrease hemorrhage during surgery. Then evaluation of patient's motivation, Then improved healing after surgery. These all can happen when we do a scaling and oral hygiene instruction. But the correction of pathological migration of teeth cannot be happen due to these initial treatments, because once the pathological migration happened already, so we cannot correct that. Next is, which of the following teeth are most often lost as a result of periodontitis? Is mainly the upper molars. Usually in the periodontitis case, the affected tooth would be the upper teeth, whereas due to caries, the most extracted tooth is the lower molars. First molar, they are the most frequently extracted tooth due to dental caries. Next is, the primary objective of periodontal debridement is the removal of what? Periodontal debridement is different. We need to understand the difference between all these. Uh, Scaling means it's a removal of calculus or deposits, supragingival and subgingival. Whereas root planing means it's the smoothening of the reference surface of the referent root surface or the cementum of teeth. Here we remove cementum because the endotoxins are present here in the cementum, so we need to remove that to remove everything. So in the case of root planing, we remove cementum. And curettage is different. That means this curettage is mainly do in the case of pocket case, where we need to remove the necrotic tissues and the lining, soft tissue lining, all we remove with the help due to this curettage. But the periodontal debridement is, it's a removal or disruption of dental deposits like the dental calculus from the tooth surface and within the periodontal pocket space without deliberate removal of cementum. That is really important. We don't remove cementum here. So that is a major goal of this periodontal debridement that you need to understand. So a primary objective of periodontal debridement is removing the calculus, not the cementum or dentin. So that is the answer. I think now you understood about the difference between these four. And next is not a risk factor for periodontitis. Just discuss now that smoking and tobacco can affect periodontitis. Poorly controlled diabetes, poor oral hygiene can all these all have direct correlation with periodontitis, but the coronary heart disease has no direct correlation with the periodontitis case. The next is, the epithelial attachment, does it migrate apically in gingivitis case? Hyperplastic gingivitis case, the epithelial attachment loss won't be there. Whereas in the case of juvenile periodontitis and chronic periodontitis and rapidly progressive, these all are periodontitis case. Here the pure attachment loss, bone loss, everything would be there. So the answer is hyperplastic gingivitis. Next is, histologically the periodontitis is distinguished from gingivitis by increased collagen destruction, increased gingival inflammation. No, it's about by the apical migration of the dentogingival epithelium. Based on that, we can differentiate between distinguish between periodontitis and gingivitis. Then in chronic periodontitis, the causative microorganisms are found in not in the periodontal ligament or not in the pocket. It's mainly not in the alveolar bone. It can be seen mainly in the connective tissues of the gingiva and also the periodontal pocket. Next is, severe chronic periodontitis is defined by the attachment loss above 5 mm. I mentioned earlier. This is a different topic that I will discuss later. Then the most important diagnostic element in assessing the periodontal status of a patient is the mobility of the teeth, not based on the depth of pocket or the result of vitality. So it's mainly we will diagnose this by the by determining the mobility of the teeth. Next is, the diagnosis of periodontitis is clinically demonstrated by the loss of periodontal attachment, not based on the bleeding or pain. It's based on the attachment loss. And which of the following is most appropriate in the management of chronic periodontitis? The answer is doxycycline. This chlorhexidine is not the answer. It's a antiseptic, topical antiseptic. Nystatin we give, this antifungal drug we give for candidiasis and all like the fungal diseases. Acyclovir is antiviral. We give that for the viral diseases like HSV and all primary herpetic gingival stomatitis, and that cases we give acyclovir. This is anti-tuberculosis drug. So we it's a doxycycline is the answer. Next is the periodontal condition showing localized advanced vertical bone loss involving first molar and incisor is diagnosed as aggressive periodontitis, because that is the classic feature of this disease. So it's a rapid progression, and dramatic attachment loss and bone loss can be seen on the specified teeth like first molar and incisors. The next is an early radiographic sign of chronic periodontitis is here. When you see this picture, this is a normal appearance of the interdental bone. Can you see? This is a normal appearance. This lamina dura and these all are intact. Whereas here, in the case of periodontitis, you can see the discontinuity of the alveolar bone. See here, it's not intact with the tooth. So the fussiness and a break in the continuity of the lamina dura at the crest of the bone distal to the incisor. So can you see this left side? So these are the wedge-shaped radiolucent areas at the crest of the other interdental bones. So the answer is notching of crestal lamina dura. That can happen initially in the case of chronic periodontitis, not the widening of vascular canals, not the enlargement of the interdental medullary spaces, and not the decreased radiolucency of interdental trabeculae. The main feature is this. So this is the answer. Next we will discuss about the next question is NSAIDs such as ketorolac are beneficial in the treatment of periodontal disease because they reduce prostaglandin E2 synthesis. So that is this way this NSAIDs work. They inhibit and even completely abolish the prostaglandin synthesis, because prostaglandin induce the inflammation like the heat, swelling. See, these all are due to this chemical prostaglandin. So they reduce this synthesis, this ketorolac. So by that way it works. So the answer is this. Ketorolac is the acetic acid derivatives of the NSAIDs. So this is ketorolac. This is the classification. Those who don't know about this, you can just refer here. You can refer here. The next question is, what is the primary source of elevated collagenolytic activity in chronic periodontitis? You know this. Before that, you need to understand about MMPs. They are the matrix metalloproteinases. They are the type of collagenases. They help in the destruction of the collagen. So this chronic periodontitis case, the destruction of the collagen can be seen. This is due to the collagenase, type of collagenase like MMPs. These are released by the neutrophils. So in the connective tissue, this neutrophils, during the process of inflammation, this neutrophils, they release this. So the primary source of elevated collagenolytic activity in chronic periodontitis is by the neutrophil. They release this MMPs and destruction of the collagen happen. Then which of the following is not a characteristics of periodontitis? Is hypertrophy of gingiva, that is a gingivitis case. Other than that, pocket formation, destruction of PL, periodontal ligament, alveolar bone resorption, all can be seen. I think today that is enough. The remaining, the rest of the questions I think I'll discuss later. Or else I'll discuss this too. A patient successfully treated 8 years ago for moderate chronic periodontitis. They treated for the chronic periodontitis case and now presents with generalized erythematous and edematous gingiva with BOP. That means they have only problem in the gingival level. there is no clinical or radiographic evidence of further attachment loss. So now the diagnosis is not the periodontitis, it's the gingivitis. So the answer is gingivitis, not the chronic, aggressive and recurrent periodontitis. And at a 6 months recall visit, which of the following indicates that gingivitis has progressed to periodontitis? How we will come to know that the gingivitis has progressed to periodontitis after 6-month recall visit? Is based on the attachment loss. We cannot identify that just by bleeding on just by seeing the bleeding on probing or any change in the gingival color or the tooth mobility. We can see the attachment loss, how it is improved or not. The predominant organism associated with chronic periodontitis are the I told the gram-negative anaerobics like Prevotella intermedia and P. gingivalis. That is the answer. The next is the severity of the course of periodontal disease depends on the A, B and C is the answer. Resistance of the host, virulence of the organism and number of organism present. Means number of organisms means when the periodontal disease progress from gingivitis to periodontitis, a greater number of anaerobic organisms they colonize deeper in the periodontal pocket. So the number of organism is also there. So these three are the answer. Then the cell-mediated immune response to bacterial plaque in chronic periodontitis is regulated by, by hearing the cell-mediated immune response is due to the T cells, whereas the B cells, they helps in the humoral responses. So the T cell cell-mediated response means the involvement of lot of cells and they kill the organisms like the T cell function, the cell mediated response, they due to the help of this killer cells, suppressor cells. So if you know that these all are the basics, so these all with the help of these all cytotoxic cells, memory cells and everything, they try to kill the organism. So this is the cell mediated immune response is this, whereas the humoral response is due to the antibody production. So the B cell, they produce antibody in such way they can resist the disease. So the cell mediated immune response to bacterial plaque in chronic periodontitis is regulated by the T cells. So I will stop here. Some of the questions are also there, so that I will discuss later when I get time. Otherwise this video would be lengthy. Thank you so much.